material to Christine, and she had a chance to look at it and look at the length of it. She said, well, I like the material, I like the topic, but where's the coffee break? And that's paraphrasing a response that Brenda Pickleman had in 1993 when she reviewed her husband, Dr. Jack Pickleman's address. And then she said, well, don't bore them with a long speech. And I said, well, why would I do that when I can do that with a short speech? So we're going to try and reach a happy medium here. And my outline is going to be very simple. We're going to review some past challenges and threats to our profession, look at some of today's opportunities and pressure points, present the results of the survey, which was presented, or many of you participated in, and then finally give my perspectives. Now, but Senator Marco Rubio got into a lot of hot water. But I think his career is still intact. So we have faced challenges before. The college was in large part founded on the premise that something has to be done about fee splitting, which was rampant up through 1948 or maybe even longer. In 1966, some of us, not too many, experienced the enactment of Medicare by Congress. In 1966, the Medicare Act in Canada was also introduced. By the way, I have read that the Medicare document, the bill that was passed by the Canadian Parliament was 9 pages in length, compared to our current Affordable Care Act. We saw the introduction of PRGs, rising costs of malpractice insurance, defensive medicine, tort reform, everybody agrees is needed. This is still an ongoing issue. I can't say that we have made much progress there. In 1990, we were worried about, or politicians and leaders were worried about the high cost of medical care. That continues. The AIDS epidemic has been with us for 20 years, but I'm pleased to say we've made tremendous strides towards the treatment of that malady. More recently, many of you who are educators in the audience were faced with the announcement that in 2001 and 2002, the number of students applying for residencies in surgery had dropped significantly, and that sent a lot of waves of consternation through our departments. And then, of course, in 2004, the 80-hour work week. We have met the challenge, and in most cases have survived and have come up with workable solutions. Here's a slide from the match program showing what happened in 2001 and 2001 and 2002. See, right here we had about 1,025, 1,040 positions available, but about 60 or 70 of them went unfilled. Now, this was unheard of. Corrective measures were taken. Several panels, such as this one, were formed. Members of the society participated on this Blue Ribbon Committee. Changes were made in our residency program, and I'm pleased to report for the last 4 or 5 years, the number of unfilled positions each year is between 2 and 4. Now, many of us will long for the good old days. And this is a picture of hospital staff presidents at one of our teaching hospitals in Louisville, and I think it kind of sets the tone for what I view as the good old days in the practice of medicine. Generally at this time, doctors were in charge of their practice. They had a major control or input into hospital governance. Before the emergence of hospital administrators, power they now have. Doctors then were respected in their community, respected in their hospitals, and they were viewed as professionals, as physicians, as surgeons, not as providers. And I think that was good. I also liked in this era, when we got consults, it was a telephone call. Dr. Graves might call Dr. Richardson or Dr. Vitale or me and say, I have a lady up on 4K who has abdominal pain. It might be diverticulitis. This is her past medical history. I have seen her, and I would like your opinion. I'd like your consult. What happens today? A unit manager or a nurse will call you and say, Dr. So-and-so, whom you don't know because he's a hospitalist and works for the hospitalist and just came on 6 months ago, wants you to see this patient for abdominal pain or right upper quadrant pain or shortness of breath. And when we and the residents go to see these patients, guess what? We are the first ones to see the patient. We end up doing the history and physical as well as the consult. And most of the time, we don't even get a thank you. And then when the patient is well and ready to go home, who does the post-op care? We do, because the hospitalists don't have offices. I guess this is the nerve that Jay Roosevelt was thinking at when he mentioned this a year ago. So those were, I think, positives from the good old days. But were the good old days really that rosy and bright? We remember the good parts, but we must also remember that in the 70s and 80s, the death rates from breast cancer and lung cancer were still increasing mathematically every year. There was no regionalized trauma care. There was no national policy regarding seat belts, use of helmets, drunk driving provisions and penalties. And trauma was the major cause of death for all people under the age of 34. Now that might still be true today. And the life expectancy was certainly 10 years less than what it is today. And some of the social habits that cause so much disease, such as smoking, received very little public attention. Contrast that to today, where in most public buildings, restaurants, schools, smoking is not allowed, and the public health efforts to curb smoking and establish healthy lifestyles. These have all developed since then, and so maybe the good old days weren't entirely rosy. I'd like to look at some of the issues that we face today that are of uncertain value and that maybe cause you some consternation. Surgeons becoming hospital employees, the electronic record, the growing number of patients without insurance, the concept of never events, penalties for readmitting patients to hospital, medical student loans, and the Affordable Care Act. I'm not going to focus on all of them, but today I'm going to focus on these four. And just to show you where there is room for improvement, and there may be some false expectations for some of these requirements that Medicare and Medicaid have placed upon us. Let's take first the readmission to hospital within 30 days of discharge, part of the Affordable Care Act of 2010. Currently in 2013, there will be penalties for readmissions within 30 days for these three conditions: acute myocardial infarction, heart failure, and pneumonia, with a payment penalty to the hospital for that readmission. 2 years from now, the list is growing longer. There will be additional added to the list will be patients readmitted for obstructive pulmonary disease, coronary bypass graft surgery problems, percutaneous coronary infections and other vascular procedures that have infection, and with a stiffer payment penalty. Is this justified? We know that sometimes very good hospitals, very good doctors who follow best practices do not observe that the readmission rate necessarily indicates that they have treated the patient poorly or that their results are inferior. This was a study put together by Dr. Eric Schneider, where he looked at 149,000 patients using the Medicare database, and included in this study were patients who had all operations for colorectal surgery, both benign and malignant, and the impact of length of stay. Now, as you know, in the last 25 years, length of stay has often shortened. And that is true for colon surgery. But during the same period of time, the readmission rate has not dropped off accordingly. In fact, it's gone up. And they said that more research is needed to understand the balance and possible trade-offs between these hospital performance measures. But it does serve notice that forcing patients out of the hospital when you don't think they are ready, or that setting an artificial goal of a shortened length of stay is not necessarily to the patient's benefit. And we are here to advocate for the patient. This is the Affordable Care Act, 990 pages. And for our friends from Canada, contrast that to your Canadian Medical Care Act in 1966, which was 9 or 10 pages in length. Another item we hear more about and incorporated into the Medicare and Medicaid program, CMS, in 2008 is the concept of a never event. Why was this introduced by Medicare? To motivate hospitals to accelerate improvements of patient safety by denying payments for certain complications. So they were trying to help the hospitals move the schedule along for doing what most of us would say we're already trying to accomplish in terms of providing good care for our patients. But they looked at the events which you see here, and I'll let you read them yourself, never events, C. difficile colitis. 1 or 2% of discharge summaries now from all, from North American hospitals contain that diagnosis of C. difficile colitis. Surgical site infection, how can that become a never event? Are these things reasonable? Catheter-associated urinary tract infection, and the list will be is going to continue. This is where we need to advocate for our patients and maybe go through our various societies to argue the case that these policies must be reasonable. Then we have the electronic medical record. I suspect about a third of you in this room have done training with EPIC. Has it really achieved its goals of providing better care and protecting the patient's health? Well, there is some evidence that the medical electronic record can help physicians adhere to the guideline-based care and reduce medication errors. On the con side, there's little evidence that the electronic medical record improves patient care outcomes, and there's no evidence that it improves the efficiency of care. In fact, it often, in my experience, reduces the number of patients one can see in the office and it decreases the time with patients, and generally lengthens the day. Lengthens the day, or the number of hours that your doctor works. So this has been quite controversial, and even though the federal government has mandated it, I'm not sure it's going to be in the patient's best interest. What about shortage of doctors? It is true there is a shortage of surgeons, This was amply demonstrated in a study by Dr. Williams and Ellison, presented to this society about 5 years ago. And they show that by 2010, which is now past, the shortage of general surgeons in practice will be 1,300, and by the end of this decade, it'll be almost 2,000. This is not an isolated finding. Projections by the AAMC are that there's going to be a shortage of physicians of 90,000 by the end of this decade, so in 7 years. We do know that medical schools are responding. I'm sure your medical schools have expanded enrollment. There are new medical schools which have opened. And so medical school enrollment is expected to increase by 30%. However, there is a logjam and a problem, as those of you involved in education know. There's this Balanced Care Act, or this Budget Balance Act of 1996, which still limits the number of residencies, federally supported residencies, that are available. And the AAMC recommends or suggests that the number of physicians should be increased by at least 4,000 a year to meet the need, but so far Congress has not been receptive to that. So now I'd like to come to the survey, which many of you participated in. And I thank you for that. We wanted to poll, or I wanted to poll, your attitudes about your practice of surgery over the next 10 years. It was a 17-question survey sent out to the membership, 500 members. We used a Likert response for most questions, and the response rate was 194 over 500, so just about 40%. Thank you. I'm going to show you an overview of all responders first, and then we'll break it out to academic surgeons versus community surgeons. This shows a breakdown of the specialty, which is what you would expect. Most responders were general surgeons. Most of them lived, but not all of them, lived in cities of 250,000 or more. The response rate from rural surgeons on the right amounted to 6 or 7. So that data really isn't, I did look at write-in responses, but it's not really something that we can evaluate. Type of practice: 153 of the responders are university or academic surgeons, and 41 are in solo practice, group practice, or employed by a hospital. To the question, the quality of surgical care in my area will improve or remain the same for the next 10 years. This is the breakdown of the response. I would say that about 20%, 25% think that the quality of surgical care will not improve in the next 10 years. Are you optimistic about the quality of care that your patients will receive in your community in the next 10 years? All responders. 55% said yes, 46% said no, and this, of course, is somewhat concerning. For those who said yes, what do you view as the strongest reason surgical care will improve or at least hold its own in your area over the next 10 years? 1, they pointed to advances in knowledge and technology. 2, commitment of young surgeons and residents coming into the workforce. 3, following quality and best practice guidelines. For those whose typical write-ins for doctors who said that quality care will not hold its own, pointed to there's a real shortage of general surgeons in our community. They didn't like the impact of the 80-hour work week and what that has done to the training of general surgery residents. And They're talking about shift mentality or group mentality, and no one is willing or trained to take charge of the patients in their hospital. What do you see as obstacles or danger signs that the current quality of surgical care in your community will not be able to maintain? So what are the danger signs? If you go across, you can read for yourself. There's concern, well, these were the options and the respondents answered, but we have the caliber of young surgeons coming into practice, doctor shortage, can't recruit surgeons as hospital employees, the medical record, increased practice expenses, decreasing insurance reimbursement, number of insured, non-insured patients, government regulation, and other. When I looked at the other to see what people wrote in as danger signs, threats to their current practice, these are typical responses. The reimbursement and the regulations we have, malpractice issues, too many rules, ability to attract young partners is a problem, and decline in reimbursement. Continued, we don't have enough general surgeons being trained. They mainly are specialists. At the university, it's difficult to pay competitive salaries and recruit academic surgeons. And then a common complaint or response was the shift work mentality. These are the big three then in the obstacles or danger signs to quality practice in the near future. Doctor shortage, decreasing insurance reimbursement, and government regulations. These three top the list. How do you see your level of satisfaction over the next 10 years? Very promising, pretty good, about the same. That accounts for 70%. 30% say more difficult and less satisfying. Now, is this significant or a change from what would have been reported 10 or 20 years ago? I don't know. Everybody might have an opinion on that. I'm sure that 100% of our profession has never been happy at all times, so we would have 100% satisfied. Now a comparison of the academic surgeons versus those in community practice. And really, the responses are very similar. This is a distribution of their specialty. This is where they live. No great change there. And of course, now this is 200 out of 500 who responded. What's your opinion about the quality of care over the next 10 years? Will it improve or will it deteriorate? And I would say that on the academic side, 80% say it will stay the same or improve. With a similar distribution, maybe a little bit more negative in the community group. Are you still optimistic about the quality of care that your patients will receive? And again, the breakdown's about the same. It depends on whether the glass is half full or half empty, but about 55–60% are optimistic that the quality of care will continue. Typical comments from those who are pessimistic about quality care in the next 10 years. The shift work mentality, shortage of surgeons in outlying areas, not enough surgeons to do the acute care surgery. And those who are optimistic about care in their community, strong mentorship for young surgeons, residents better every year. Again, what do you see as obstacles or danger signs in your community? It's the same three, whether you're in academic or you're in community practice. Doctor shortage, decreased reimbursement, and interference, perceived interference from the government. How do you see your level of practice or satisfaction? There's really no difference between the academic surgery group and the community surgery group. About 70% seem to enjoy and look forward to the next 10 years. What are two things that you will continue to enjoy about your practice? Not surprising answers: helping patients and families. They like operating. They like teaching residents and students the interaction with partners, nurses, and staff, and patient contact. So in summary of the survey, challenges and changes in our practice are a given. Most surgeons in the survey think there are solutions to our problems. Now that could get a debate going. Most in this case means 70%. It is clear that the welfare of the patient must remain a priority. We must strive to maintain our professional status as opposed to being providers only. And our surgery residents offer a source of renewed hope, energy, and commitment. How can we advocate for our patient and provide higher quality care? Well, through our practice, holding firm against discharge planners and others in the hospital who are promoting early and pushing for early discharge. We need to role model patient safety and welfare as a priority to our students and residents and colleagues. And we need to join and support organizations that promote your concerns, goals, and patient safety, such as your state chapter of the American College of Surgeons, your state medical society, the American College of Surgeons, regional societies such as the Central, and then supporting the political action committee of the college, which really argues and lobbies on our behalf. Remember the oath of Hippocrates that we all took when we graduated from medical school. The one point that stands out today is the health of my patient will be my first consideration. I'm encouraged when I look at characteristics of the medical students in our incoming classes. I talked to our Dean of Student Admissions yesterday, and he confirmed that the main reasons students list on their application for applying to medical school are these: a real desire to help people, a sense that they are good or gifted in science, and or that they like science, and the applicants have often been influenced by a personal experience with illness or injury or that of a family member. What other qualifications? Let me tell you, they are very talented. The GPAs at our medical school have remained stable and high over the last 2 decades at 3.6, but the MCAT scores at our school in Central America are the highest ever. Of those who are accepted, the average score is 10. Of those who apply, the average score for their MCAT is 8. So what are reasons to be optimistic as we come to a close this afternoon, ladies and gentlemen? Well, one, you said so in the survey, 70% of you did. The demand for surgeons of all types is great. That has to be good news for the residents and fellows in our audience. I think we have to have faith in the nobility of the human spirit. We might be down at times, but we shouldn't be out. And just look at what we've been through before, and we've come up with solutions and have survived. We still are recruiting the best and the brightest residents into surgical careers. We still enjoy patient care, and we have and will have remarkable opportunities for new technology, imaging techniques, access to information, improved operations, and treatments that we did not have even 10 or 20 years ago. Points to be optimistic. And then I take great heart in our residents. This is a group on rounds at our VA hospital recently. A few are in the audience here. And it's just an example, I think, of the vim, vigor, vitality, enthusiasm, and commitment that they have. We hear things about Generation X. We hear things about Generation Y and the millennials. But don't listen to that, but that's not the total picture. We have talented people coming in our footsteps, and with that belief in the ability of the whole the human spirit, we will do well. And with that, I'd like to conclude my remarks, and thank you so very much for your attention. You are most welcome. There will be a business meeting this afternoon at 4:15 or 4:30. And right now, one of the pleasures of the presidency is to host the new member luncheon, which is out front here. We have a record number of new members. So those of you who are new members, please remember that. Thank you very much for your attention.